So, hi everybody, my name is Nens van Alfen. I'm a neurologist from Nijmegen in the Netherlands. And I have the honor of doing this ultrasound demo for you for the AOCCN 2021 edition. First off, we are going to show you how to set up your machine. It's a very basic demonstration and course of system settings. We are going to show you some basic nerve techniques and some of the tips and tricks for scanning the most common nerves. But let's start with the equipment. As you can see, we have a subject in this room. We have the machine set up here. We have our ultrasound gel, which you need to replace every day for hygienic reasons, or use sterile gel. We have some towels, and you will need a lot of those usually. And we have some cleaning towelettes for the ultrasound probe in between patients. Assuming that you found the switch to turn on this machine, we're now going to start the ultrasound software. And in this case, it's a combined EMG and ultrasound software system. And then the next thing you're going to do is select the correct probe and system settings. So first you enter patient details. In this case, we're going to start a new study. We assume this is still John Doe who wants a new study done. And we're just going to select any nerve here, like the median motor. And the system's going to come up with your basic EMG in this case. So now we need to switch to the ultrasound setting. So we're selecting the ultrasound here. Press OK. And here is your B mode system coming up, the brightness or grayscale ultrasound. Now, in this case, there are two probes attached to the system. The one we want to use today is the high frequency probe, which is here. And there's another one that you could switch in the back side. So you've chosen the right probe, which is a high frequency linear probe in this case to do nerve ultrasound. And the system has come up with a B mode screen. And now we need to zoom in a little bit to see if we've selected the right depth setting, which is 30 millimeters in this case, and whether we have the right gain setting, or the overall volume of the sound waves, and the right focus. So let's just say I want to change depth. This is the yellow button here. I can change it to 40, but I could also change it back to 20 millimeters, which might be enough to see the median nerve at the wrist. And then the focus probably needs to go up a bit, so I'll just set that. And let's say we want a somewhat brighter image. I'm going to increase overall gain, which you now see increasing from 61 to 67 in this screen. Next thing you're going to do is put some gel on the probe, which you can see. You can see the artifact here on the screen. And now you want to know which side is left or right. Well, usually there's a marker somewhere, but I'm not so familiar with this system, so I'm just going to tap the probe and see whatever end of the probe is moving. This is actually the right side, and this is the left. I'm now going to put the probe on the wrist and see if I've chosen the correct settings. Mind you, this probe cord is heavy, so maybe you want to wrap it around your arm or wrist or neck to make sure that it's not holding you back. So we've just put this probe on, and now we can start doing our scanning. So sometimes you have a slightly different ultrasound machine, and it's good to get familiar with your system. This is a slightly older model. You need to fill out a name here. So let's say I type the A in the screen. And start the exam. Now in this case, you see there are two probes attached on the side. They come off pretty easily. You just click them open and you remove them. The system is going to go ask you what you're doing. Click them back in, and it will come up with that same probe. I can select here which one I need. I'm not sure if you can see the small screen here, but there's the two probes. I can select a musculoskeletal application. And then I'm going to do the upper limb and say OK. And the system is going to create that preset for me. This is a more classic type of ultrasound machine. The last one you saw was an integrated solution. Now in this case, we've also selected this probe here. It's a 3 to 13 megahertz probe, so it's relatively low frequent, this one. It's now set to a musculoskeletal. Same thing applies here. I can move the depth around with the buttons. There's some measurement protocols, and now I can just start scanning. Let me show you one more machine. Okay, for this demonstration, we are going to use this particular machine. It has very little knobs, so there's not a lot that we can do to set the presets ourselves. But we need to select a probe, and we've selected this 15 to 6 linear transducer, 15 to 6 megahertz that is. And we are going to scan the median nerve. I've asked Tom to be as much to the left on his bench, so we have a lot of room for his arm, and then to slightly supinate his forearm so we can look at the median nerve. Mind you, I like to have people, I want to look at the screen, I want to look at his face, be able to communicate with him, and I want to be able to sort of handle the machine and handle the probe without being uncomfortable or stretched apart like that. So this is a good setup. If we're going to do the other arm, we would move the machine around to his other side. And if we need to do the feet, we're going to go to the caudal end of this examination bench. So again, we're checking what's left. Well, left is left on this. This probe around my neck because the cord is heavy. And just start by putting the probe on the wrist region. Now, I know what a nerve is here. It's quite superficial. But let's say I wanted to scan the mid-forearm. You can hardly see the bones here, so I'd need to adjust the depth. What is the optimal image depth here? Well, in this case, this is the radius. It's the radial side of the hand. And you can just about see the ulna there. So those are bone echoes, and there's shadow underneath. You can't see through them. Okay, you see a lot of stuff here that I'm going to explain later. For now, this is the median nerve right in the middle there, between the flexor muscles. And you can see on the screen that these are muscle structures. And of course, the skin and subcutaneous fat, which he has little of, is on top. Now, we're interested in nerves, so we're going to go back, have a little more detail here. And you can see the nerve bundles lying there. We'll just follow them to the wrist. I'm running out of ultrasound gel, so I need to put a little bit more on. Usually I just mark the nerve's course like that. Sort of visually reminds me where I need to go. Check again what's left. I always try to keep the left of my probe towards the left of the screen. It's more intuitive that way. The only reason not to do it is when we are scanning in the sagittal axis, then you want to have left towards the head. But in this case, it's very intuitive. And especially if you start putting needles in here, you don't want the needle coming in from the top left when you think it should be the top right. So left is left. Okay, so we had that median nerve right in the middle here. There's other structures there like these tendons. And now this is just basic imaging. You can see the branch of the median nerve. It's going to be the palmar branch coming off it. And when we go towards the wrist, there's a lot of structures here that are oval and have dots. So it's flexor carpi radialis tendon, flexor tendons. Tom, could you move your fingers? And then your thumb a little bit. Sort of when you're typing. And you can see these tendons moving the nerve around. Okay, thanks. If you're in doubt whether this or that is a nerve or tendon, let's say we will follow this one. If you follow it back, you can see it will change into something else. It changes into muscle. So that is definitely a tendon, and this is the FCR muscle anatomically. You can see the tendon curved out here. If we follow it back distally, and you can see it sort of contracting, becoming a tendon, and then the nerve is underneath it. I think this is the most foolproof way of discriminating between a nerve and a tendon. Just follow it back proximally and see where it ends up. For the median nerve specifically, this is the only structure that, if you go from wrist to forearm, will follow a C-shaped course. So it's right in the middle on top there. And if I go towards the forearm, it's going to make a C-shaped curve and end up here in a deeper layer between those flexor muscles. And that is very easy to track. It's the only structure that does it, so you'll be quite certain this is the median nerve. Now, of course, this is a transverse scan axis, so you slice the nerve in its shortest axis, so to speak. We can also measure it that way. But we can also do a longitudinal scan, of course. And for that, it's easiest to just put whatever you're looking at right in the middle of the screen, and then very, very slowly twist the probe, centering on that middle of the screen. So if you think you're sliding off the structure you're looking at, go back, do it more slowly and start again. But here, you can see the probe twist 90 degrees, and there is the nerve in view. It is a little more difficult than scanning a vessel, because a nerve is, well, more continuous with the surrounding fascia, for example, especially smaller nerves. But this is a sure way of getting a good longitudinal image. And you could also follow the nerve in a longitudinal direction, which takes a little practice training. I've frozen the image, but it's kind of blurred. I was moving when I did that. Most machines will allow you to track back a few frames until you have that nice picture here. And when you think the image is optimal, you can press save and store it. And we store it with a name, so in this case it's AOCCN, of course. But make sure you annotate, because I'm just showing you this picture, you have no idea what we're looking at. Probably you're guessing it's a nerve. But we know from the scan direction that the left is proximal, so I'm going to annotate this. And it was the median nerve, and we're on the right. Don't try to make long pieces of text, just something that you will recognize afterwards. Right median, and this is the proximal part of the image, for example. And I will save it again. We can also measure stuff. So this is just a simple, quick diameter measurement. Not that I'm really interested in diameters in this case, but I want to mark the nerve for later review, so that if someone else is looking at your image, it's really easy for them to see what you were looking at. And we save it again. So in this case, we're going to take a further look at the wrist. What else is there to see? Well, basically we had that median nerve that's right in the middle of our screen right now, there. So still checking if it's the nerve. Yes, it is, because it's making that curve. It's right on top, and you can see some other oval structures around it. If I angulate the probe, you can see that they will go dark pretty soon, like this. And you're making use, if you do this, of the anisotropy effect. The tendons have much more pronounced than the nerve itself. So the nerve sort of stays the same, while the tendons get black. There's some other stuff to see, of course, because you can see blood vessels on the left. And if I put them in the middle of the screen, you can see that the two little ears on the side, they are actually veins. They are blinking at you. That's because I'm compressing them slightly. I can turn on any color mode. The machine usually has a Doppler or color flow mode. And you can see that there is some flow in these vessels. Mind you, this is not an optimal setting for vascular imaging. And the other thing is that the best image for a nerve is a 90-degree angle, so the brightest image you can get. But the optimal scan direction for any vessel will be 60 degrees, so you would need to tilt it. So keep that in mind when you're trying to look at vessels or vasculature around the nerve. The other thing you see is that there is a bony structure here, deep, which will be the distal radial bone. And if we scan further, you can see the small bones of the hand region popping up. And then we are already in the carpal tunnel. I need to angulate slightly because the nerve is actually going to go steeply down underneath the carpal ligament. So in this view of the carpal tunnel, you can see the carpal ligament on top, the nerve lying below it. It's already separating in several bundles, and it will need to. And on the other side of the wrist, you can see the pisiform bone there with another artery. This, of course, is the ulnar artery. If you're in doubt, you can check it like that. And next to the ulnar artery, you can also see the ulnar nerve between the artery and the bone. So that is Guillaume's channel. Now we've already seen that as well. If we go back to that median nerve, you can sort of appreciate it looks like it's got 3 fascicles here, which is slightly unusual. So we might want to check that little middle fascicle there if there's a vascular signal in it. And maybe it's a persisting median artery. Not yet. There was a little vascular signal in it. So actually, Tom has a bifid median nerve at the wrist with a small persistent artery there. It's something to note in your report, and you need to, if you're going to measure this nerve, it's good not to include that artery part. So for measuring a nerve, now we can also see that that artery is right there. It's probably a little more conspicuous here. There it was, showing itself. If we want to measure the nerve, we don't want to include it, so we're going to take this image, stop it, freeze it, and then just put in a trace or ellipse tool here within the epineurial rim. It's easiest to do this across the long axis of whatever structure you're seeing. You can fold it in until you're happy that you've included all the nerve tissue within that epineurium, which would make for a nerve of about 6 square millimeters, 7 square millimeters in this case. If you're satisfied with your region of interest here and your measurement, you just save the image. If we go back to the longitudinal images, running into the carpal tunnel, we're putting the nerve on top, twisting the probe 90 degrees, so you can see the nerve here, running into the carpal tunnel over the bones of the wrist. And here you would be able to see if the nerve was still mobile. If it's been operated on or it's really stuck with carpal tunnel syndrome. Here you see the nerve moving when I move the fingers. If there's severe carpal tunnel syndrome or there is some fibrosis that's hampering this movement, you will not see the nerve move. And that is a situation where the patient is at risk for symptoms. So you can look at the gliding here. Well, we've looked at vascularity, we looked at the longitudinal images, the other structures that are around here. Please also be aware that these, of course, these tendons, they can have fluid around them, they can have synovial cysts. So if anything else shows up besides the nerve that looks unusual, please also mark that in your report. Okay, next thing that is important when you start scanning is that you have some landmarks to find the nerve. So median nerve at the wrist, I've already shown you, is that C-shaped curve, and it's the honeycomb structure here, in this case with an extra vessel that's going to lie on top. The C-shaped curve is a very good giveaway that you're actually looking at the median nerve here. And from this spot, you can of course trace the nerve all the way back to its very proximal origin if you want. So this is just a forearm. We need a little more depth here when it's running under pronator teres. And you need to angle the probe to make it more visible. But now it's already between the two heads of pronator there. So right in the middle of the screen. I'm going to go towards the elbow. It's going to lie next to the brachial artery. You can see the elbow joint here with the cartilage lying on top. You can decrease depth a little bit because the nerve is right on top there. Don't need a lot of depth. You can see the artery pulsating next to it. And then you can track it all the way to the upper arm. Another landmark, in this case for the ulnar nerve, is also in the forearm. So now we're switching to the ulnar nerve. We've looked at the median here. The ulnar obviously will be on the ulnar side. So we're going to turn this arm out a little bit and going more ulnar. You see the bone here, that's the ulna. And a good place to find the ulnar nerve, if you're not sure, or if it's something anatomically wrong, like a trauma, is to look at the ulna and this beautiful oval-shaped muscle lying on top of it, really on the ulnar side of the arm. This is flexocarpi ulnaris. It's lying on top of the deep finger flexors, and the nerve is also sort of under it. If you are, like me, visually inclined, you could say this looks like a breast with a nipple, but then inverted, right? So if you can find the nerve here, you can track it to the wrist. And now you can see the small round structure coming up from the deep. The nerve is there. This is the ulnar artery. And in over 95% of the people, it will join the nerve sort of mid-forearm, and they will course together towards the wrist. They are friends. They will not separate until they are in Guillen's channel. So they're right here, more superficial because flexocarpi ulnaris is turning into a tendon. You can decrease the depth a little bit. And at this point, the ulnar nerve sort of elongates here. And what you can see now is actually the branching off of the dorsal ramus. So the dorsal branch of the ulnar nerve just came off there, this little part, with a small artery coming from the ulnar artery. And this is the rest of the ulnar nerve running into Guillen's channel. We are very ulnar here. You run into the bone. So now you need to go a little more to the radial side and sort of enter the tunnel from there. So not try to do that because you're running into the bone. Turn the probe around and look into the Guillen's channel. And then the nerve is there, wedged between the bone, the pisiform, and the artery. The next nerve we're going to scan is the ulnar nerve. Of course, we all know it's in the ulnar sulcus on the medial side of the elbow. If you're looking for it and you want to find it quickly in the upper arm, it's a little dorsal. You can also see that I've used the machine setup and some towels to create a position where I can get behind the elbow to scan that nerve, which is really important because only then you have a nice 90-degree scan angle and a good view. So actually you start on the medial side of the arm, but a little dorsally, and then you can see the nerve coming into view here, and it's embedded in the triceps. So it's in the triceps muscle. There's a small vein right next to it here, which I can easily compress. If I do so, you might notice another nerve there, right next to that vein. That is actually the medial antebrachial cutaneous nerve. So it's also in this vicinity. And another branch of it is right there on the other side of the vein. But we're going to look at the ulnar here, right? So it's in the triceps. And usually the ulnar nerve has a small vessel that's accompanying it somewhere. And I might, from the looks of it, it might be this little guy, but let's just check. So there it is. That's a small artery. And it's very common for the ulnar nerve in the upper arm to have an artery accompanying it. You don't want to use or take this in the cross-sectional area measurement, so please make sure that you know which of these small dots is not belonging to the nerve, right? So we can now follow the nerve and we go dorsal and we want to enter the sulcus. I've already put some gel there. I'm going to put some more in there because there's little subcutaneous fat. So I need some. And then just see if I can get behind the elbow like this. Okay, so the nerve is on top. I'm going to decrease the depth because we don't need that much for the sulcus region. And here you see the nerve entering the sulcus. And it's actually right there next to the bone. And it's quite hypoechogenic. The edge is hyperechogenic. There's a little texture in there of the fascicles. This is a nice view of that nerve. We can measure it here in the sulcus, within that epineurial rim again, so within the white contrast-rich edge, which is here, so 8 square millimeters, which is fine. And then, well, of course, we need to follow the curve of the sulcus. So the nerve was here. We started there. It's actually a little bit on top of the epicondyle here, sliding over in the sulcus region. Now seeing the olecranon across the sulcus. And then we're in this region, distal elbow, where you can see the nerve right under the double attachment of the flexocarpi ulnaris muscle. This is the cubital tunnel region. It's also a compression site. Can be a lot of pressure on these two proximal heads of flexor carpi ulnaris and a thick tendon that is joining these heads together. So it's a fascial band across the nerve. This is cubital tunnel. And from this point on, this you've already seen, this is the flexor carpi ulnaris with that nerve hanging from. So this is the elbow region. Again, this time distal to proximal, entering the sulcus. You need to adjust the probe direction here because the nerve is going around the bend. You keep it in view, adjusting slightly every time we move the probe. And then here it goes a little more medial. And I'm not sure what would happen if I would completely flex this elbow. It might be that it subluxates here. So it's in the sulcus there. Let's just see where it goes. You flex his elbow. A little more. Nope, it stays in. Don't know if it hurts or anything, but no symptoms. So, distal from the elbow, if you find this difficult to round that bend, it can be at first, it can be really hard to sort of join these two together. Why not just start here in the ulnar nerve and scan it up till this point, and then start there and scan back and join these images together. You don't need to be able to do that right away. You can also join these regions, right? So if you're here beneath flexor carpi ulnaris, we're going to scan it further down the forearm. There's the ulnar artery that runs with it. And again, this is the part we've already seen where it's in the distal forearm. This is where the dorsal branch separates from it and runs towards the ulnar side right there. If you want to find the radial nerve, we need to go, or the easiest spot to do that is here mid-upper arm. And the radial nerve sort of comes across from the humeral groove. It has to come from the posterior side of the arm to the ventral side, meaning that it has to transit the ligament or the fascia that is between the ventral and dorsal compartment. Now, in this case, on the left, I have the probe quite laterally. You see the triceps, of course, the humeral bone, and then brachialis here, lying under the biceps. And this is the spot where the nerve crosses that fascia between the anterior and posterior compartment. Sorry, the machine just beeped there, so just checking. So it's right here. You can see it coursing through the fascia here. I don't need all this depth, so I'm going to sort of optimize the image a little bit. It's right next to a vessel, and you really need to keep twisting that probe to keep it in view because it's sort of twisting itself around the bone. But here it's quite clear. You can turn on the color Doppler if you're not sure which one is the artery or which one is the nerve. It's actually one artery with two veins right next to it. And then the nerve is crossing through that fascia there. And it's entering brachialis muscle, actually between brachialis and brachioradialis, which has its origin here, and then running to the ventral side of the elbow. So let's increase that to show you. From this place on, it's much easier to go to the ventral side of the elbow to keep that nerve in view. So this is the radial nerve here. And that nerve is going to separate in two parts. Sorry, it's right there in the middle. And it's sort of separating here. You call this a snake eye view in two little branches, which will be the deep and superficial radial nerve. But just for your reference as a landmark, if you are really unsure and you can't find the distinction between the ventral and the dorsal side, just put the probe on the deltoid muscle, which is a little more proximal. You see the three heads here. Slide down. I'm going to put a little more gel there to make that easier. Slide down. And then you see the deltoid disappear, meaning that triceps is going to be the next muscle on the dorsal side. And there you can see that neurovascular bundle crossing the fascial lining between the anterior and posterior compartment again. So this is a good way to scan for that crossing of the radial nerve from dorsal to ventral. So of course we can also look at muscle tissue. In this case I put the probe over the sort of midway across the biceps and brachialis muscle in the upper arm. You can see the humerus, the bone there in the middle part of the screen, humeral edge. And you can see the separation between biceps and brachialis. So the lower part, which is more bulky laterally, is brachialis. And then the top part, separated by this line, you can see the musculocutaneous nerve running in it, is biceps brachii. This is a muscle in a transverse slice. It's dubbed a starry night appearance, so a black sky with some white stars, and a few lines in there as well. If you twist the probe 90 degrees for a longitudinal view of muscle, you can see the fiber direction. So biceps and brachialis are really nice longitudinal running muscles. You can see the fibers and some small intrafascial arteries and nerve elements here. And this longitudinal direction is a great way to scan, for example, for muscle tears and hematomas, which will interrupt this longitudinal structure. So muscles, there are also landmarks for muscles. So biceps is easy to recognize here on the humerus. Try to get a good view of the whole bulk. You can ask the subject to actually contract the muscle. Could you make a fist and then release it? And then do that a couple times. And again, a little quicker. And you can see the muscle contracting there. You can even see the two heads moving separately in this area. It's the separation. Thanks. So in the forearm, we could scan the whole flexor compartment here. Note that I have a little bit deeper setting now as we've had for just this median nerve there. You can see here flexor carpi radialis, palmaris longus lying on top. You need good anatomical reference knowledge for this. The deep flexor layers, which are sort of between or underneath the line from the ulnar to the median nerve, here and there. And then flexor carpi ulnaris there. So same here. Of course, these are multiple muscles, so if you take them in a longitudinal view, you can see multiple fiber directions in several layers here. This would be a good way to scan forearm flexors and compare them. And another muscle we can scan is the first dorsal interosseous, which is of course between the thumb and the index finger. You can make a transverse scan, sort of midway the metacarpal bone. We don't need that much depth for this muscle, so you can see it here. It's the one on top there, really nice muscle. There's always a small artery and a small digital nerve in the corner right there. You can also twist this around 90 degrees. And then you get the longitudinal structure of the first dorsal interosseous. And also the adductor pollicis. So that is scanning the FDI. And most commonly, if I scan from the proximal to the distal region here of that muscle, this is proximal, and now it's sort of midway. And here we go distal. You can see the bulk and the contours changing. Usually we try to scan the muscle at the point of the maximum bulk, which would sort of be here, and then take some images there, right? That's the most informative part of the muscle. So here we're going to scan the distal sciatic nerve and the perineal and proximal tibial. Maybe you can see that I've already drawn out the anatomy on the surface here in gel. It's sort of a visual clue for myself what I'm going to do. The easiest landmark here would be to start in the knee fold. So exactly the spot where the knee bends. And then put the probe in the lateral half of that, just on the skin like this. And in this region, the perineal nerve should always be in view. If you can't see it, you can't see it, but it's here. We don't need as much depth right now, but you can see the peroneal nerve lying there, almost on top in the image. If I go a little distally, it becomes quite superficial there. This is the surest way to find a peroneal nerve. If you start 1 centimeter up, it's getting a lot harder because of its oblique course. And if you start further caudally, it's difficult sometimes to discriminate it from the fascial and tendon attachments of biceps femoris. So just that knee fold, lateral half, put the probe in there, and there should be a peroneal nerve in view right there. Okay, if you have this nerve, first thing we can do is track back up and follow it. We need to angulate the probe to give a good 90-degree angle on that nerve. Follow it to the deeper part of the knee region, where you can see another nerve here. That is the tibial. And they are joined together, of course, and form the sciatic, which we can now see here. Okay, so this is sciatic nerve, which lies under biceps femoris. That's a good landmark for the sciatic. And we could track that nerve further back up the leg if we want. It's not for this demo, but if you're there anyway, why not check the distal part? So they separate here. You can see them splitting apart, and we're going to follow the peroneal again, fibular as it's called now. Sorry about that, I'm a little bit old-fashioned when it comes to this name. And I'm going to decrease the depth a whole lot to get a more detailed view of that peroneal nerve. You need to adjust the probe angle, so tilting it a little bit. So it's right there. I keep tilting so it sort of highlights the nerve from the tissue. And if you look closely, you can now see that a small branch is splitting off. There, that little one. This is the lateral sural nerve. So that's the first thing that's going to come off the peroneal is the lateral sural nerve. Okay, when we've seen that, we can go towards the fibular head. So it becomes quite flat here under the attachment of biceps femoris. And then here is the fibular head. There is no entrapment in this case, but if you're not sure, you could stop here and measure the nerve. Again, we're going to measure the nerve within the epineurial rim, just using this ellipse tool. So this is the epineurial rim. We'll take it in a long axis, so fold it back on itself, that ellipse, and it's 9 square millimeters, which is okay. If you want to follow the peroneal nerve further, you will have to twist the probe around, sort of to the lateral and then ventral side of the leg, right? Because the nerve is going to turn around the fibula. And it's going to be quite oblique. So I need to do a lot of angle correction here to keep it in view. But it's now split in 2 parts, these two. And you can still see them. You can see the vessel here. This is the superficial peroneal nerve. That's the deep one. And now we've followed it all the way around the fibular head. So here we're back, going back to that sciatic region, deep in the knee foot here. Okay. Could you turn your leg out like that? Right. You could also put a little pillow underneath or anything to make it more comfortable during scanning, or a towel or something. Just going to put a lot of gel here because he doesn't have much subcutaneous fat, so we need a little padding not to end up running into the bone. And the tibial nerve, a landmark for it is the vessels that accompany it. So usually you can see the tibial here. I'm not sure if you already have it in your view, but it's right there. And there's 1, 2, 3 vessels lying sort of next to it, on top of it, which are the tibial artery and its 2 veins. If you go a little more distally towards the tarsal tunnel itself, like so, usually these artery and veins, they're going to look like a Mickey Mouse with ears, where the artery is the head and the ears are the veins. Let's see if that's true. Can I compress them? Yes, I can compress the ears, so they are veins, and the head is still visible. Now, the tibial nerve is right next to the ears, right? This is the tibial nerve here. If you're not sure, turn on the Doppler and check it again. So there's the head of Mickey, and there's not enough flow for this system in the ears, so to speak, in the veins. But you can see them here. The nerve is sort of next to it and slightly under it. And from here on, it's going to split in several parts. Please be aware that if you measure nerves at the point where they branch, from that point on, the size will be sort of the size of the original nerve divided by the number of branches, so 2 or 3, plus 1 or 2 square millimeters of new epineurial layer. So you need to add those to the eventual branch, right, for a reference value. Now, we could also track that nerve back up into the calf. So it's here. You can see the dots in the honeycomb structure. I'm going to run back into the calf region here, where it's going to be deep from the soleus muscle. So this is soleus. That's the nerve. It's still next to the vessel, and this vessel will accompany it for the rest of its course through the calf region. So you could increase depth and follow it some more. And if you have a little more practice, you could just scan that all the way up to the knee again. And if you can't find it, just look for the artery, right? It's going to be right next to it. So this time we're going to start scanning the sural nerve. And if you are doing EMG already, you know where to find that, right? So usually if you want to stimulate it, you look for that small saphenous vein that's running here, and it should be right next to it, sort of 10-15 centimeters proximal from the heel. So let's just put the probe there and see what happens. Okay, we can see the vein there. And it's usually a good place to start looking for the nerve, as in most people it's right next to it, which is the case here as well. I'm going to decrease the echogenicity a little bit. Let's just see. You can actually see the nerve right next to that vein. Mind you, to scan this, you need a very light touch and enough gel, right? Because if I compress, the vein is gone. And it's really hard to see what the nerve is in all these small subcutaneous structures. We haven't looked at the subcutaneous layer much, but in this case, you have, of course, the skin, which is on top of the image, and then a small layer of fat, which is black, with these white lines, and those are actually lymph channels. It's a fascial structure that carries lymph fluid. So if you see that vein, you can see that in these lymph channels there are some very small fascicular structures, and that is the sural nerve. And if you found it at this point, just by you stimulate it with EMG, you can follow it towards the ankle. It's really small there and separated in 2 branches now. There's a branch on the other side and there's a branch here. You can just track it all the way to the medial ankle and see if something happens. You know, maybe it's damaged with surgery or something. You can also track it back up. It just crossed the vein. You see, from left, this is going to the left side. It's right there. Let me put that in the middle of the screen for you. And now it's going to cross under the vessel and emerge on the other side. Very small subcutaneous nerve. They all look like this, same as superficial radial, etc. This is the sural. And the landmark for it is that small saphenous vein, which is really easy to find. So just look for this in the distal lower leg. The good thing about any nerve is that if it's damaged, it's usually much bigger. So if you are unsure if you've seen it, but you didn't see any caliber changes, you're probably okay. If we move the machine a little bit, and I'm going to clean them up later, we can look at the leg muscles. For example, rectus femoris, which is a very good landmark in the upper leg. There's a little more gel here. To look at rectus femoris, we just put the probe on. You can see we really need to increase depth because we can't see the femur, so at least a couple centimeters more, it's right there. And then rectus is that beautiful oval muscle here with the central tendon line, it's oblique. This is a very good recognition point and a starting point anatomically for scanning anything in this upper leg. Of course, it's vastus intermedius. If we go medially, this is vastus medialis. If we go laterally, this is vastus lateralis, which is a huge muscle. And then if we would go further out and to the posterior side, we would transit from vastus lateralis, of course, into the hamstring region. And we can't even see it in him because the vastus is so big. Rectus is usually recognizable. If it's hard, go distal, because this rectus will turn into the patella tendon first. So now it's sort of gone, the muscle tissue, but here is the tendon part, and the other parts of the quadriceps are going to insert onto it, to the knee. So you can start at the knee and just go proximal until you see that oval-shaped muscle. Very recognizable and a good starting point for anything in the upper leg. And a latter standard muscle to show you would be tibialis anterior, which of course is on the peroneal compartment. And it's the first muscle you're going to encounter when you start at the tibia. So tibia is here, the tibial bone. This is the interosseous membrane. And then here's the shadow of the fibula in the deep part. And you can see tibialis anterior is a beautiful bipennate muscle, all the fibers attaching onto the central tendon. It's like the flight of a dart arrow. So very recognizable. Also here we try to find the point of the maximum bulk, which we sort of crossed just there. So I'm going to go back a little more proximally to this point of the maximum bulk. Now, you can see the peroneal nerve lying there and the deep peroneal artery. You could put the Doppler on if you want. This is the interosseous membrane, and this is a deep toe flexor compartment. It's actually tibialis posterior. So if you do botulinum toxin injections blindly and you normally scrape this muscle, you scrape the tibia to get there, you could also just find it here, right? It's 3.5 centimeters deep. If you just stick the needle in straight down, there's nothing else in its way. The vessel is out there. So it's a real good way to point and orient yourself anatomically. If we move further out, you will see different muscle structures here. So this is peroneus longus, extensor digitorum longus and peroneus longus, which is a bilayer muscle. And of course, if we go across the tibia, we need a little more gel. So we were here on tibialis anterior, crossing over the tibial bone, which is of course a big shadow in your image. And right now we're in the calf compartment, where the first muscle, which is actually superficial, is the soleus, and there's the medial gastro. And then you can scan all the way to the back until you meet the lateral gastro. Probably you'd have to turn it around to see that one. But this is medial gastro. This is soleus again, and medial gastro. And here again, you can twist the probe 90 degrees around, and you can see the beautiful fiber directions, which is a much more steep angle in this muscle than it was in biceps. Okay, so as a final example of muscle, I can show you some pathology that I carry with me. It's quite handy for demos. So you see my left calf here, and I'm going to show you the medial gastro, which is this muscle lying on top of the soleus. And as you remember, this looks like the starry night appearance of a muscle. Okay, so it's in the longitudinal direction. You can see the fiber angle, you can see pennation angles running into the fascia. And in the transverse, it's that dark image. It's a small vein on top. And this is what a calf should look like. Now, the other one on the right looks a little different. So this is the right calf muscle. Here is the tibia for your reference. And you can see that it's quite bright. There's a few holes in it, which might be vessels and fascial lining. And it's kind of hard to see through it. You know, you can't really see the soleus, which also looks a little, well, damaged. And this is the end result of complete denervation. So in my case, 2 times an S1 and S2 radiculopathy. That left this cuff completely denervated. So this is what abnormal muscle would look like. This is completely fibrotic. You can grade this. It's a HECMAT grading scale that we use, where a normal muscle is a grade 1. If it's slightly hyperechogenic, but you can still see its muscle, it's grade 2. If it's very hyperechogenic and you sort of lose the muscle texture, it's grade 3. And if you have a completely white muscle like this and you can't really see through it because all the ultrasound is already caught in this upper layer, it's a grade 4 muscle. So I can twist this 90 degrees and you can see it in the longitudinal direction. It's really hard, there is no discernible muscle fiber anymore, it's just a small fibrotic layer. So this is what damaged muscle looks like.